Kamal sir, should we go ahead?
Yes, sir. I feel we can go.
Yes.
We can start the meeting. Live stream is also on. Shilpa,
Okay.
you have started the live streaming?
So, good afternoon to everybody. All respected executives of the National Association of Pharmacology and Therapeutics and dear participants. In last 2 weeks, we have completed 4 sessions of good clinical practice on overview of good clinical practice, responsibilities of stakeholders in clinical trials, then clinical trial protocol and informed consent process. Also, NPT has circulated the PPT as well as video recording of the last 2 events. As usual, if anybody wants to ask any question, they can post the question in chat box and we will take it during the discussion or will be answered by the speaker in the chat box also. Today again, this is our third session. We are having 2 new topics. First is on ethics committee and individual responsibilities of members, which will be taken by Dr. Usharani Pingri madam. And the second session is on national ethical guidelines for biomedical and health research by Dr. Nandini Kumar madam. First session will be moderated by Dr. Lalit Kumar Gupta sir. Presently, Gupta sir is working as Director Professor of Pharmacology at Lady Hardinge Medical College, New Delhi. Sir has worked as a member of Ethics Committee as well as Animal Ethics Committee in his institute. Sir is also member of various subject expert committees of DCGI. He is also member of the National Pharmacology of India to 2021 and National List of Essential Medicine 2016 and 2021. Sir is also subject expert in pharmacology for National Board of Examination and is having more than 40 publications in peer-reviewed journal. I welcome you for this session, sir. The next session will be moderated by Dr. Mirza Siraj Beg sir. Beg sir is currently working as professor and head Department of Pharmacology, Government Medical College, Sambhajinagar, Maharashtra. Sir is also Deputy Dean of Academics and sir has attended around more than 170 international, national, regional CME as well as workshop. Sir is also member secretary of Ethics Committee and member of the Scientific Committee of the Institute. He has been invited as a subject expert by the Ministry of Health and Family Welfare for the revision of National List of Essential Medicines. He has also acted as a subject expert for ICMR projects on drug development initiatives, proposals, approvals in 2020. Sir is having more than 100 publications in national as well as international. Welcome, sir, for the session. Now I request Dr. Lalit Kumar Gupta, sir, to introduce today's first speaker, Dr. Usharani Pingre, madam. First session will be of 25 minutes, followed by a question and answer session for 10 minutes. Over to Dr. Gupta, sir.
Oh, thank you, Dr. Dakhale, for my kind introduction. Now, it's my privilege to introduce the distinguished Dr. Pingley, who is the speaker of this, our first session. Dr. Usharani Pingle, she is a senior professor and head of the department in clinical pharmacology at Nizam Institute of Medical Sciences. She is working actively in her institute as shown by her membership in she is member secretary at NIMS Ethics Committee for Stem Cell Research and Therapy, and she is a assessor for NABH for Ethics Committee, and NABH assessor and Ethics Committee coordinator for ICMR product development, and she is also SEC Subject Expert Committee member for DCGI New Delhi, and she has worked as a member of Harvard MRCT Post-Trial Access. She has received prestigious UK SHIT Award in Indian Pharmacology Society presentations and LK Oration, and her list of publications is more than 130. I welcome her, and it's my privilege to be a moderator in this session. Madam, please, you may start with your presentation.
Sir, is my slide visible?
Yes, madam. Yes, madam.
Yeah, okay. I thank the organizers, especially Dakle sir and Kamal sir for giving me this opportunity, and Dr. Lalit Kumar for introducing me. The topic given to me is roles and responsibilities of EC members, to which I added the additional continuous monitoring of clinical trials by ethics committee. So before we start off, I thought if we could just pause on a small case, like the research assistant gives a trial participant a much higher dose of test medication than was stated in the protocol. So this raises a couple of questions like what actually happened and what is the EC's responsibility in such a situation? You can just think about this and we'll come back to the answer a little later. So we all know this is a new NDCT rules which have come up in 2019, which actually revolutionized the clinical research scenario in the country. And among the many highlights, a few which I thought will be significant is there's no change in the safety reporting process and timelines. There's no significant change in the compensation process and requirements. And the onus of providing medical management to the subject lies with the investigator. And they had note on the post-trial access. And of course, they made a mention that EC accreditation is voluntary, not mandatory. If you go into the little more details of it, the chapter 3 talks about the ethics committees for clinical trials and BA/BE studies. They mentioned very clearly on the ethics committee constitution, the changes made were a minimum of 7 members from medical, non-medical, scientific, and non-scientific areas with at least 1 layperson, 1 woman member, 1 legal expert, 1 independent member from other related fields like social scientists or an NGO, a philosopher, ethicist, theologian. And they went on to say that 50% of the members should be non-affiliated. And every EC shall require to undergo, as EC member needs to undergo training and develop in the development program. So what is the impact of this? Several EC ethics committees had to reconstitute to comply to this rule. And this also had some impact on the ongoing studies due to this reconstitution. So that was a matter of little concern. And the validity of ethics committee registrations was increased to 5 years. So this becomes a little less cumbersome. The renewal of registration, many people had are in doubt like how to register, when to register. The application for renewal of registration is to be made 90 days prior to the date of expiry of the registration, which means that this allows the EC to continue functioning for a longer period if the renewal application is submitted on time. And then the proceedings of EC for clinical trials, any change in the membership or the constitution needs to be intimated to the DCGI within 30 days. And this needs to be complied with. And maintenance of records, again, they say that more comprehensive requirements for maintenance of records by the ethics committee 5 years after completion of the trial. That is, they're supposed to maintain for that long. So EC again had to make some changes in the SOPs. And a note on suspension or cancellation of registration. So whenever the ECs fail to comply to these rules, then this can happen. So there's another ethics committee for biomedical and health research introduced. So the details of which are given in the national guidelines very clearly. And this is mostly for ECs for biomedical research and academic research studies. So the impact of this is that the ECs ethics institutes had to revamp the existing ECs, and for which they were given about 6 months' time. They may constitute a separate EC, or the same ethics committee can see the regulatory as well as the academic research projects. But the biomedical health research ethics committee, that needs to be registered. That's the academic and trials, the research projects that this committee which is seeing had to be registered with the Department of Health Research. And the constitution is as per the regulatory guidelines. And the registration, again, application for registration to the Department of Ministry of Health and Family Welfare. So initial, the DHR registration is given for 2 years and later renewed for 5 years. So this is a very important document which we've always been discussing, and I think Madam will be taking this a little forward. So I'll just focus mostly on the basic responsibilities of the ethics committees. So which is basically concerned with protecting the rights, safety, and well-being of the research participants and maintaining ethical balance between ethics and research. So going to the composition, affiliation, qualification of individual members and their roles. The quorum, as per the guidelines, says the minimum of 5 members should be there in the meeting, of which include medical, non-medical, or technical, non-technical, which is because our ethics committees are multidisciplinary, multi-sectorial ethics committees. So they will be covering all the aspects of the members, and no decision is valid without a full quorum. So this is something, again, very, very important. So that's a chairperson. You can have a vice chairperson who acts as a chairperson in the absence of a chairperson, and the same should be mentioned in the ethics committee SOPs. The chairperson is non-affiliated, so this is again important. The deans, directors, or head of the institutions, and so on cannot be the chairperson because this is an independent body. And as per the qualifications, it randomly says it should be a well-respected person from any background with prior experience of having served or serving in an ethics committee. And the chairperson is one of the most important persons because they're responsible for conduct of the meetings and see that everything goes in an independent manner and the ethics committee functions reasonably well. And then more importantly, they should ensure that there is active participation of all the members, especially the non-affiliated and the non-medical, the non-technical members in all decisions and deliberations. And then, of course, the conflict of interest forms need to be signed, and the chairman assures that. And he's also responsible to see that the quorum is complete for fair decision making, because any decision made without the complete quorum is definitely not valid. And then he handles complaints against researchers, ethics committees members, conflict of interest issues, and requests for use of ETC data, etc. So the next person is equally important is the member secretary, and member secretaries, they are normally affiliated to the institution. They should be a staff member of the same institution with knowledge and experience in clinical research and ethics. And they should be having adequate time, which is very important because most of the responsibility lies on the member secretary to organize meetings, conduct the meetings, prepare the agenda, distribution along. This is done with the help of the secretariat. And any SOPs need to be updated, that has to be done. And then the members trained on those SOPs. And they also need to prepare for and respond to audits and inspections, and ensure there's complete documentation, because without documentation, it did not happen what the GCP says. And assess the need for expedited review or exempt for review or full review. Sometimes there is a gray area, and so that needs to be decided by the member secretary. And assess the need to obtain prior scientific review or from an independent consultant, as the case may be. And of course, again, ensure regarding the quorum. So the basic medical scientists, they can be affiliated or non-affiliated. And as per the guidelines, the qualification is a medical person or a non-medical with qualification in basic medical sciences. And if the ECs are reviewing clinical trials with drugs, it's always better to have the pharmacologist as the basic medical scientists. And basically, they need to do the scientific and ethical review with special emphasis on interventions, seeing the risk-benefit analysis, the research designs, the methodology, statistics, and then also on the SAEs and protocol deviations and so on. And for clinical trials, the pharmacologist needs to review the drug safety and pharmacodynamics wherever applicable. The clinician can be affiliated or non-affiliated. And if you have 2 or 3 members, it's always better to have one who is non-affiliated. And the qualification is there should be individuals with recognized medical qualification, expertise, and training. And they need to see the scientific review of the protocols, and especially the risk-benefit analysis. And they need to concentrate more on the ongoing review of the SAEs, the protocol deviations, the medical care of the trial subjects, what is inbuilt in the protocol and what is actually happening, the facility, the appropriateness of the principal investigator for provision of medical care, management, and compensation, because that is the duty of the principal investigator. So the clinicians should see that all this is inbuilt there. And thorough review of protocols, investigators' brochures, if any, and other documents which are submitted. Then we have the legal expert who may be affiliated or non-affiliated, who should have a basic degree in law from a recognized university. And it is desirable that they have training in medical law, because this dealing with clinical trials and research is a little different from the routine cases they handle. So the legal expert actually needs to review the proposals, that is informed consent form, translations, the memorandum of understanding, the clinical trial agreements, the approvals, the other site approvals, the researcher's undertaking, protocol-specific permissions, and all which is required as per regulatory guidelines. So clinical trial, just a point on this. Suppose you have a sponsor and you have CRO, then care should be taken to see who is going to handle the compensation and whether there is a proper agreement between the sponsor and the CRO, because if the CRO is interacting with the investigator, then all this needs to be mentioned very clearly in the clinical trial agreement as to who is going to take care of what aspect. The social scientists, the philosopher, ethicist, and theologian, they can be affiliated or non-affiliated. And they should be individuals with social, behavioral science background, or religious qualification or training. And they may have expertise, and they should be aware of the local cultural and social obligations. And it can be even an NGO related to health activities. They normally review the proposal, the informed consent form, along with the translation. So this is again something important, because as I always say, you can have a Google translation when you do a translation, and you can even have a certificate. But the translation and the back translation needs to match. You may have a back translation, which again looks like the translation, but the versions need to be, the translated one need to be very clearly looked into, because Google doesn't have so much of intelligence as to interpret exactly what the investigator is thinking of. Like if you have, we had one protocol which says for elderly falls, which means elderly people, a fall means girjana. But unfortunately, it was decided as, jharna, like a waterfall. That was the meaning which came out. It was a translation, it was a back translation, meaning seemed right. They got a certificate. But when you read everything clearly, then, these sort of things do come up. So this is something which is very important and needs to be looked into. And also they have to look into, the cultural and social religious aspects, because we had some studies where you see what happens now the Ramzan season has started. So what happens to the sugar levels in people of that community when they don't take hypoglycemic drugs during so many hours and so on. So this is again something which is very important, and then they serve as patient they are representative from the society. It can be especially for some cases when you're dealing with some HIV and stuff like that. So, they have a very important role, which is not normally exercised by most of them. Like the lay person, again, these people are non-affiliated and they may be a literate person from public or community, but there is a very gray area onto their qualification, because as an NABH assessor, we have seen PhDs and postdocs being lay persons. So are they really lay? Again, that's a gray area. So they should be ideally from the community, aware of the local languages, and they should be involved in the local activities. And even they have to see the ICDs and see the ethical aspects of the protocol, evaluate the risk benefit, like from a layperson's perspective. Is it okay, not okay? What is the risk? Is it clearly mentioned for a layperson to understand in the informed consent, and so on? So I think I'm going to, so the EC functions is review, decision making, interim review or an expedited review, monitoring, and then the special population. So I'll be going a little fast because I think we're going short of time. The expanded role of EC and monitoring of clinical trials. This has come up after the new HLQ's declaration, which talks about the more dynamic aspect. Earlier it was just approval, but now it is more dynamic process, which involves monitoring, overseeing of the consent process, and then even they have a role in deciding the compensation. So it is a more dynamic activity. If it is not done the right way, then, the studies can come up like this in news, which is not very favorable. So monitoring procedure, this was, I've received some questions from some of the participants on my WhatsApp saying to discuss these aspects. So I've just managed to push in some. Monitoring procedures, who should be monitored, how to monitor, and when to monitor. So I think it is a good idea to divide it into high, medium, and low risk. The low risk would just require, they would just not require an on-site visit, but there you can just review the 6 monthly updates as per the SOPs, and then because these are no risk, low risk, so you don't have to, may not require an on-site visit. Whereas a high risk will require more intensive and frequent monitoring of data, seeing the consent process if required, and compliance with whether there is adequate human protection given, especially in the phase 1 studies and so on. Well, the medium risk can be, and a random sampling can be done, and then that can be reviewed, and a site visit can be made. So it's a good idea and a convenient idea to divide so that you have something in place, and this should be mentioned in your SOP. So review intervals was another question. So most of the time, it is always depends on the nature of the study and the events under that research. So if you're having phase 1 study that requires a more, regular follow-up, and then, but otherwise at least once a year, and this should be mentioned in your SOP. So EC functioning during pandemic, I just wanted to have a word on this, because this was an extremely important period where the ICMR had come up with wonderful guidelines which talked about how to handle in pandemics. They have a section 12 which talks about the research during humanitarian emergencies and disasters, And I think everyone should read this. And then, because what is more important as far as an ethics committee is concerned is you cannot meet face to face, and you have to be aware of the technology, because the new COVID research projects had to be is reviewed. Now we can say new pandemic research projects, non-COVID research studies, as well as ongoing non-COVID research. So there are 3 different entities which had to be handled by the ethics committee. So the SOPs had to be again redone in some cases. So this was a very difficult situation. So going to the regulation of IRB, do you think it has to be regulated? Because the registration of ethics committees has come into place, 122 DD. And then they went on to the accreditation. Now, accreditation is the act of granting credit or recognition, and it is the process in which certification of competency, authority, or credibility is presented. Now, the ECs did feel that they are in par with everything. So do they need to be certified to reflect their competency and credibility? So that was a tough decision, but still it need to be done, because you need to have uniformity of EC's functioning, because because there are a lot of gray areas, so this needs to be filled in. The qualification, experience, and knowledge in ethical issues is a requirement for which you need to have SOPs on the training, and that needs to be complied with. And then they need to know about the applicable rules and regulations, because most of these, there were a lot of issues when we actually went to the ethics committees for accreditation. And of course, documentation also was a very important aspect, which was not complied by in some places. So with the ethics, because the basic need of role of ethics committee members is to ensure scientific integrity and protection of trial participants' rights, safeties, and well-being. So summary of the standards, I'll not go through all that because of the lack of time, but I just speak on 1 or 2 of them. That is a self-assessment and record keeping, because these were some of the areas where there were a lot of lacunae. So the ethics committees need to have a periodic self-assessment, and then you need to have, appropriateness regarding the composition, attendance. Again, this was a major thing. They had members who never hardly attended the meetings, and SOPs. So everything should be there in the SOPs, and that should be complied with. So to assess, to do the periodic assessment, there should be a review process, either a checklist or an internal audit. And then what were the corrective and preventive actions taken, if at all? What was the root cause and what was the action taken? And then the whole thing needs to be documented. So now who's going to assess what? Either you can have some internal assessment committee doing it from the staff of the institute, or you can employ somebody. That again should be mentioned in the SOP. Record keeping and archiving was another major issue. So security, confidentiality, and integrity of all the proposals and associated documents should be reviewed from time to time. There should be an SOP for archival and confidentiality in retrieval. So again, that's very important. That's why I made it in red. Not only for the archiving, but even to retrieve, you need to have some sort of a SOP. And then documents and records to be archived after completion. What is the archival facility? And how to archive soft copies also you need to have an SOP for that. And then, yeah, I've talked about the good things. So now, having said that, what are the challenges which ethics committees faces? No funds allocated or very little funds allocated. Space crunch, that is especially in government institutions. So to have documentation and archival facility becomes very difficult. Infrequent meeting, because everyone has a 9 to 4 job, but still time needs to be taken off. And then at least tentatively when the ethics committees are going to meet should be mentioned in the protocols, in the SOPs. Lack of trained staff. That is why you need to have training records maintained, staff to be regularly trained. Limited resources for monitoring studies. Again, this was a major aspect which we did observe in our audits. And not all research studies undergo review. Again, approvals are given, but how many studies you're going to review? Is there an SOP? And then is that being complied for? Is that again important? So summary is independence and competence are hallmark of a well-trained EC. And the current approach of regulatory authorities to delegate powers to EC is definitely commendable. There is no doubt about it. And only empowered ECs can elevate the standards of ethical review and ensure human protection. So having said that, I'll just get back to the case where we left. So yeah, if any answers are there, you can put in the chat box, you can deliberate. But since the time is short, I'll just go on a couple of points in relation to that. This type of non-compliance does happen. It did happen in a couple of instances which we have observed. And of course, sometimes it can even lead to long-term consequences and death. So the IEC should regard this incident as serious, since it was caused by protocol deviation and unnecessary harm to the participant. And then, the EC should decide to set up a committee to review the incident and see how you can prevent. This is the corrective procedures which need to be followed. So the investigator needs to be monitoring the study staff and be present, at least accessible. And the investigator is on leave or travel. There should co-investigator or the co-PI should be there. Pharmacists need to be trained on correct use of the study drugs, and then the sponsor needs to train again the investigator and the study staff to handle, especially the people handling the study medication. So with this, I think the time is up, and thank you very much, because the stringent scientific evaluation of a clinical trial protocol and the vigilant monitoring are essential requirements for efficient conduct of clinical trial. And if there are any questions, I shall be happy to answer them. And thank you again for giving me this opportunity. And of course, I have Nandini madam here with me, and madam has been my mentor. So good afternoon, madam. Yeah.
Good afternoon.
Yeah. So any questions, sir? Lalit Kumar.
Yeah.
Yeah.
Thank you, Dr. Usha Rani ma'am. You have given insights on a very important topic of how ethics committee should function, what are the important responsibilities, and how to avoid common mistakes. I think we must be having a lot of questions, and I am unable to access the chat box. If any one of the co-hosts.
Okay, sir, I will go ahead with that one. Madam, one question is there. What is the role of ethics committee in academic trial if there is any serious adverse event and there is no corpus fund for any serious adverse events in the institute? So in this scenario, what will be the role of ethics committee?
I think there should be some sort of setup for the corpus fund or some sort of insurance taken, because whatever rules apply for a regulate academic do apply for the academic clinical trials also. So that needs to be set up, and that's the institute responsibility. And I think the guideline very clearly says that it is the institute and the guide's responsibility to see that things are set up in place.
Okay. Madam, next question is dual role allowed by DCGI in reviewing the clinical trials by the ethics committee member?
Yeah, this again has been a matter of debate, because as per the guidelines, yes, the member secretary can be a clinical pharmacologist also. So there is a dual role, means a chairperson and member secretary, if you're talking about that.
Yes.
Yeah. But you cannot
because it is allowed by academic trial,
but
not in the clinical trial.
Yeah, but one thing which is not allowed is if a social scientist has also a legal degree, then the person should be either a social scientist or a legal person, but they cannot take two roles like that, So that is not accepted.
Madam, next question in the chat box is, should honorarium be paid to internal members of ethics committee,
See, that
those
is
who are from the same institute?
that is again, the policy of the institute, whether they want to pay or not. Some institutes pay, some institute like our institute doesn't pay because it's part of your duty is what they say. So it is all again, it's an administrative decision by the institute. That's it. But there should be some sort of a receipt or something kept. If anyone is taking honorarium, even external members, they should have some receipt or something to say how much they're being paid, because they can't be paid undue amounts.
We can take the last question. That is, on how many ethics committee single person be appointed? Is there any guidelines by DCGI or the ICMR?
Actually, I am, as far as I am aware, I think Madam is here, but there's no such restriction on the number of committees a person can be a member, but they should have adequate time for doing all the activities. And then, especially if they have to go for monitoring, it's within the 50 kilometers radius or something of the ethics committee. So ideally, if you have a 9 to 4 job, I don't think you can justify your work as a member of ethics committee if you are there in too many ethics committees, because with the expanded role, there is a lot of work for the members.
Okay. Thank you so much, madam. Now we can go ahead with the next topic. Thank you, Gupta sir, for the moderation.
Yeah.
Now I request Dr. Mirza Beg sir to introduce today's second speaker, Dr. Nandini Kumar madam. Again, this session will be for 20 minutes, followed by question and answer session for 10 minutes. Over to Dr. Beg sir.
A very good afternoon to one and all, the organizing team and the delegates. It's an honor for me to introduce an esteemed speaker for this next session, Dr. Nandini Kumar. As regards to her current status, she is president of FERCI Ayush, Distinguished Scientist Chair. She has a role to play, or has played a role, as former Deputy Director General, Senior Grade ICMR. Her area of interest is bioethics, and that to traditional medicine research. As regards to the important achievements of Madam, few glimpses which I have. She is involved in ethical guidelines for ICMR, NACO, and Ayush. So preparing the ethical guidelines, it is a definitive task, and I hope those important guidelines are reflective of her work. She is a pioneer in promoting bioethics education in India. Fortunately, I am also associated with bioethics of an institute level, so I can understand how important it is. She has been a faculty for diploma and master's course in bioethics and clinical research. She has also acted as a member of President Obama's Commission for the Study of Bioethical Issues. She has been a national and international surveyor for ethics committees, senior consultant for Niti Aayog, recently concluded G20, BRICS, WHO, NIH, EU, and other agencies. And she has been also involved in DSMB and OSMB. I'm honored, madam, to welcome you all. Over to you. Eager to listen to you. The delegates are requested to put their queries in the chat box. Thank you so much. Over to you, madam.
Thank you very much. I am audible. Can my slides be seen?
Yes, madam.
Yes, ma'am.
Okay. At the outset, I would like to thank Dr. Kamal and Dr. Ganesh Thakle, with whom I mean, especially Dr. Ganesh, with whom I have been interacting about this program. And also thanks to Dr. Beg for introducing me. I just want to actually cut this thing, and this is coming in between. Are you seeing only the slides or also the messages that are pouring in?
No, slides only, madam.
Only slides.
Only slides, madam.
So maybe only I am seeing that, 10 people entered the waiting room and things like that.
Yes.
So the thing is, when we talk of guidelines in our country, it will not be complete picture unless we describe about what existed in our ancient India. So the first documented code was in the 30th century pertaining to Siddha medicine. And thereafter in Ayurveda scenario, Actually, there is a dispute about when it started, when it ended, and things like that. But suffice to know that it was from 10th century onwards, BC, to 200 AD. I have written only Charaka Samhita, but there are others like Sushruta Samhita, Vagbhatta, and so on. And then we have Hammurabi in the 1st and 2nd century AD. But it is the 4th century BC Hippocratic tenets which have become very, very important because it has given rise to modern medicine as well as Unani medicine. Now, whatever medicine you take into account, it was actually, the underlying idea was to gather information which may be acquired for the benefit of patients, which has nothing but research. So when we say code, it was practice related, that I would say will not be completely correct, because it took centuries of their research to come to the guidelines that are now present as classical authoritative texts of these traditional systems. But today, they have to prove their therapies to the global, scenario to emphasize that their system also has a value. So that's the way, our societies have developed. But coming to more modern times, in India, the first statement that was released was in 1980. It was just an 8-page booklet. And then 20 years later, we had the first blue book. Then the more 6 years later and 11 years later, we had the 2017 guideline, which again, there was a lot of actually effort which had gone in the first revision. And the second one was actually given to me as in charge of the changes, and I had no support, etc. So the exercise could not be that extensive, but we were able to bring out some changes in that. And then the 2017, which again was a very, very big exercise. Now, I don't know, I was fortunate enough to be at least associated with these 3 guidelines. And when the next guidelines come in, I don't know whether I'll be party to that or not. So the present guidelines, 2017 one, the 3rd revision, actually has, what you see, has 12 sections. So what you see in red actually are the new entrants into this. There were no takers for public health and social and behavioral sciences. So it was felt important that if it comes through the ICMR portal, then people will accept it more. So although there was a guideline released for social sciences, but that was not accepted because it was from a private sector. So these actually got incorporated in this guidelines. And then what you see in blue, informed consent, vulnerability, biological materials, and research. They were actually mentioned in that as some sections, but they got expanded to such an extent that they became separate sections here. So earlier in the guidelines, we used to call chapters, but for some reason, it was decided that this guideline, we will term all these as sections. So coming to the first section on general ethical principles, essentiality, the principle of essentiality is the one which actually highlights the fact that if science is bad, ethics is bad. So this is the one criteria on which, there's a lot of argument in the ethics committee. When ethics committee tries to point out, mistakes in the science, then the investigator, especially a very bully type of investigator, would say, what business do you have to discuss science? It has gone through the scientific review committee. Who are you people to talk about the science? You look at the ethics. No, that is your duty, your ethics committee. But that is not true, because ethics committee, as Usha had already described, the composition from that, it is very clear that there are actually scientists also sitting in that committee. The advantage is that they are not, bound by the authority of the institution, so they can actually opine more openly and find the loopholes or the gaps in the proposal that has been submitted. So essentiality actually pertains to the science of the proposal. Voluntariness, non-exploitation is also self-explanatory. We'll talk a little more about privacy, confidentiality. Risk minimization is always you try to decrease the risk and maximize the benefits. Professional competence has actually come up, was really based on the GCP, which came out in 1996. And remember the first guidelines, ICMR guidelines came out in 2000. So the thing is, I remember very well because I was actually compiling the whole thing. And at that time, a phone call came from DCGI's office. The DCGI himself, at that time, Dr. Das was the DCGI. He was asking, this guidelines, is it actually talking about the GCP? I said, yes. Oh, so he was assured about it. And we had a sentence about it because GCP got released before this document got released. So this professional competence actually comes up because of the background of ICA GCP. And then, of course, we have the blue colors that you see are the new entrants. Classically, we had these 12 principles in 2000 as well as in 2006. And there, actually, in 2006, we just added one thing about the ethics committee, the importance of ethics committee to see that the person has actually enrolled voluntarily and not under coercion. So that alone was added. And but then there were other principles, compliance, etc., which were actually taken off in 2017. Instead, social responsibility was actually replacing one of them. The point is that this, when we talk about research, it always should have a social value. But here it means is that your research should not be responsible for creating, divides among the population. So the maximization of benefit was given more importance. So this is taken off separately as a separate principles. And then you have the environment protection, the new principle. This was actually part and parcel of principle of essentiality, where there was a mention of planet, no harm should come to the planet. And that actually meant environment protection. So this is taken off because this had assumed more importance because of the new technologies, like the nanotechnology, for example, and then the environment itself, the pollution leading to so many diseases, etc., etc. So one word about institutional arrangement is that research should not be conducted in an institution which cannot support it. Somebody was asking about, how to take care of the injury, compensation for that injury, There's no excuse. The institution has not taken insurance, group insurance, or does not have a corpus, then it has no business to actually conduct research. And they can get into trouble if something goes wrong. And when that is going to happen, God knows. Something happened, so many things happen. And because of that, this NDCT rule and the amendment of Drugs and Cosmetics Act, all these followed after the Supreme Court judgment and asking the Ministry of Health, what are you guys sitting and doing? How much protection are you giving the participants? What is the compensation that you are giving? So you see, institution has to take a serious view of that, at least attempt to do that. And many times, I have also heard about private sector making the students pay for the small injuries that may happen, which should not be. That is not the spirit of research. Why is the institution standing there? It has to have responsibility and it should take that responsibility. So therefore, they should actually allow such arrangements to be made make the infrastructure strong enough for research to be carried out, proper research to be carried out. And then this research should be transparent and accountable. Totality of responsibilities. Earlier days, if some PI actually went wrong or did something intentionally wrong, then the institution would say that I didn't know that this was going on there, and that person is responsible for that. I am not responsible for that. No longer they can talk like that, because they allowed such research to happen in the institution. Then they are also responsible enough for that. So they will also be behind bars. And we see very often that when something goes wrong with an institution, it is the institutional head who is actually taken to task. So that is what is meant by totality of responsibility. So the researcher, if it's a student, then the guide, the ethics committee, the institution, and the sponsor, all these people are lined up as people who have responsibilities. So general ethical issues is actually the second section, where again more importance was given to benefit risk assessment, distributive justice, and community engagement, which actually got added as new descriptions. Privacy and confidentiality, we'll talk about it later, and then payment for participation, research-related injury, etc., conflict of interest. Until this 8. When COVID came, you heard Usha saying that a new guideline was released in 2020 to deal with the COVID situation as a guidance for ethics committee. So all these 8 principles remained in that guideline that you see here, but additional ones were added, and those were about storage of biological material, collaborative research. A lot of collaboration was happening, and the public health and socio-behavioral research, because many people were going into depression and there was lack of protection to the caregivers, etc., frontline workers. Then role of agency sponsors and governance of research and biosafety. The biosafety was very, very important because, people were handling very dangerous material, contaminating material. So those were added to that. And privacy, when we talk about privacy, it means that it's a right of the participant to keep the information to oneself. And it is the obligation of the researcher to keep it confidential. So that's why you will have only controlled access. Many times we see that these doctors, when they're going in the lift, they discuss about patients. And there are patients also in the lift listening to that. So that should not be the way that the whole thing should be treated. And when it comes to stored sample and data, the role of anonymization becomes very important. And when we talk about privacy, there are limitations at times, because sometimes, for example, there's danger to oneself, like suicidal ideation, or danger to others because of that person, or the court may actually require some details. So you have to actually divulge that. And also, I would like to mention here that if RTI actually wants to probe more information, you are not supposed to give that. You can give a general thing like 90 people have been enrolled, etc., etc. Those commonalities you can talk about, but not on individual details. So when we talk about distributive justice, you can see from this picture, it's so clear that a fat man will require a fat amount of material. And you can see how people are having different types of want, need. So this is what is called, whatever you give according to a person's need is called equitable distribution, need-based distribution. So this is actually in research, we generally use this term, equitable distribution of benefits and burden. Burden means, this actually means selection of participants. This pertains to that actually. Then what is that? burden means burden of the disease. Suppose you have a project on diabetes, and there are people, I mean, diabetes affects all levels of society. So if a rich person, I mean, comparatively rich person satisfies the inclusion criteria, that person can be included in the study. But don't restrict the study to only those BPL card holders because it is easy to manipulate them. No, we should not indulge in that. What about benefits? So this research has actually resulted in some beneficial outcomes, say. So that benefit should return to the participants. It's not like, earlier days. Now it's more and more difficult for the developed countries, especially when it pertains to India, that you do research here, go back to your country, and reap the results and utilize it only on your population. In India, if they come, they have certain obligation to do good for the local participants because of whom you got that result. So I'll not go deeper into that, and also about vulnerable population. If they have to be used, it should be actually, it should have some benefit for them also. It's not that they should be used for the benefit of others. This is what I was telling about equitable distribution of burden and benefits. It should not lead to social, racial, or ethnic inequalities. This was all, what I was trying to say, the social responsibility, the ethical principle about social responsibility. And then benefit sharing, wherever possible, if there is a benefit accruing, that should be shared with the participants, the researcher, the institution, whatever you decide. But this has to be decided before it is the research is initiated. So you will find that in the ICMR guidelines, in many places, you will find this word benefit sharing. Then payment already, Usha has already highlighted about that, so I'm not going to go into detail about that. And then if any additional medical services are required, it should be free of cost. Many a times, the legally authorized or legally acceptable representative actually takes advantage of this position, and mostly it is the money part they may be interested in. And then the ethics committee has to be vigilant about such a possibility. The other things included in the general ethical issues is the investigator-initiated research and student research, community engagement, communication of research findings, because the researcher has an obligation to inform the research results to the participants. And then again, mention about post-research access and benefit sharing. Now, student research, we have seen many proposals where the student is actually termed as the principal investigator. If you look at if you abide by the good clinical practice, a student can never be a PI, because there's qualification, attached to the role of PI. That is your training, expertise, and qualification. So you have to be qualified for that. That is not enough. You should have a training in that and also have the experience. So a freshly passed out postgraduate student cannot be a PI also, because doesn't have the experience. So that's why you will see that in most of the funding agencies, they gave them a junior level fellowship and not as PI. Then the section 3 is about responsible conduct of research, which is very important. This was actually very much talked about in the international scenario. So it was felt that India should also talk about it to be at par with this international scenario. And let me also tell you at this juncture that the Indian guidelines are actually accepted, and only guidelines from the developing country which are accepted by the US. And you know very well that the US doesn't, agree to certain things with the ease because they think that they know the best. But this is one place where the Indian guidelines, the ICMR guidelines, have a place of pride. So, so it was felt that the responsible conduct of research, which the Americans talk about, the Europeans talk about, and there's a world movement about that. So we should be at par with them. So that's why this chapter was actually introduced as a new chapter. And this is about responsible conduct of research, which means that you should actively promote honesty, accuracy, and all good adjectives that you can attach to that. But you have to adhere to the ethical principles and the professional standards for the responsible practice of research. These are the actually the points highlighted in that: values of research policies, planning and conducting. I will not go through this the whole way, because you will get the slides anyway. And this is all in the interest of time. Only thing in policies, I would like to highlight that animals, if you are going to do experiments with animals, then you have to qualify for that. And of course, it goes through the Animal Ethics Committee, which is stricter than the Human Ethics Committee. And this is the scenario not only in India, all over the world. Animals are considered more important than humans. Anybody who can tell me the reason for that? Anybody? Time is running out for me. I think probably people are muted. So the point is that the animals cannot, protest or cry like humans can. So you need to actually safeguard their interests much more than the humans. So conflict of interest is a very important point. You actually design a study and all that with considering your professional judgment. And that is called primary interest. Again, all adjectives come in there, fair, the designing of the thing should be proper, and you have to have fair distribution of the people who you will enroll, and so on. Be honest, etc., etc., etc. But it is all based on the professional judgment. But now this professional judgment can get influenced by a secondary interest. And that secondary interest can be non-financial or financial. So this can be academic. You want to promote your students, your PhD students, your MDs, etc. So you will try to, push it faster. And then financial, you have your shares, etc. in a company, and that company's proposal has come to you for review. Then you have a conflict of interest, personal, husband and wife business, or mama, bhatija, whatever. I mean, these relations are on personal levels, which also can influence your judgment. And then political reasons, promotions and things like that. So there's nothing wrong in having conflict of interest. Most of the time, most of us would be having that conflict of interest. But when you have that, disclose it. And when the decision-making process is happening, you have to recuse yourself. That is, remove yourself from that discussion arena. After all that, you managed to submit the manuscript, the report, which will be reviewed, or the manuscript which will be reviewed by the publishers. So that's why we say that having a conflict of interest is not wrong, but there should be measures to be taken to protect from the influence of this conflict of interest. And this is not only to be declared by the investigator, but also the authors, contributors, editors, reviewers, publishers, and ethics committee. So when you plan and conduct research, there are two main issues you have to take care of. Conflict of issues is not only conflict of interest, but also conflict of commitment. I think somebody had asked that question, how many proposals can a PI have? Of course, in how many ethics committees a member can be a part of, that is another aspect. But a PI also can have 3 or 4 proposals with a large sample size, which of course the person will not be able to manage. It's very obvious. So it is the duty of the ethics committee to ask that. In fact, some ethics committees do have that submission form where these details are asked. In how many proposals, projects you are PI, in how many projects you are co-PI, and also the samples that would be drawn for a single participant, how many people will actually take blood from that? Because in most of the academic institutions, you have 3 or 4 PGs, coming to the same patient. One will draw for biochemistry. I mean, I'm talking about PGs, not routine care. They will take blood for biochemistry, another one will come for microbiology, another one will come for something else. Then the community medicine PG will come and start a questionnaire business. So you are actually targeting the same person. And over and above that, the blood is also drawn for routine care. So aren't you actually depriving that person of valuable blood when the person is sick? So these are the things that the ethics committee ought to actually observe. And then when you come to data acquisition, there are other obligations, like you have to get authorization to collect that, permissions. When you are actually doing systematic review, you don't have to bother about that because it's all in the public domain. But if you are going to have a project where you have borrowed a questionnaire which was published in a journal, then you are supposed to ask the permission of that particular author, because many times, the author may allow, but some authors may say it's my copyright, you can't. So that has to be there. Ethics committee will ask, did you ask permission of that author? Recording, if you want to record also, you have to take permission. So ownership, custodianship, we'll talk about it later. So you have done your work with all honesty and transparency. You're now ready with the manuscript. Now you have to actually publish it. So for that, ICMR advises to follow ICMJE requirements for authorship. But sometimes the authorship may, these guidelines may not give the answer for what you are looking for. For example, then in that case, institutional or department policies will help. So for example, during COVID time, I understand 256 centers were involved. So all the 256 centers will have a PI. So all of them have to be given, authorship in that particular paper. So ICMJE doesn't answer that, because here you have 256 people doing the same job. So then they have to be actually, because ICMJE asks for percentage of efforts based on which you have the authorship, first author, second author, and all that. So that's why, apart from this, if you have institutional department policies that have to be followed, and peer review. Peer review has its own problems, and if I were to take that, it will be another hour. So I'll not elaborate it much. And then, of course, it has to be registered in CTRI. Now, CTRI actually denotes that clinical trials have to be registered. Which of course is mandatory for the regulatory clinical trials, and the other one voluntary. But it is always better to register, because for publication, when you go, some of these journals may ask for the number, and then you don't have the number. So very good work actually suffered when this came about in the earlier days. Very good, which could have become good papers, could not be published because they had not registered. It's only during COVID time that all sorts of, research, whether basic or clinical, should have been registered, because people wanted to know how many, how many research, how projects or clinical trials were held related to COVID. So here, once you find out that there's research misconduct, then the institution should have policies earlier enough. not when the research misconduct happens, then hurriedly the institution calls for a committee and says we have to deal with this and all this. You need to have a framework earlier itself how to deal with certain situations. And the investigation should be held in time. And during that time, the whistleblower as well as the accused should be protected. Why accused? Because many a times it might be just a false allegation. So when we talk of research misconduct, we talk of three things: fabrication, falsification, plagiarism. Fabrication is you have no data, you have cooked up the data. And falsification is one where you have some data, but you have manipulated it to suit your requirement. Statistical significance and all that, you juggle with the numbers here and there and all that. So finally, it looks like there was some statistical significance. So that is falsification. Plagiarism is all about cut and paste. That whatever you have written, you have not attributed that particular part to the source from where you have taken it. International collaboration is also part of it. So I will not describe this in detail, except that whenever you collaborate as equal partners. Don't feel cowed down by the other party. It may be like, a very strong researcher, and then the other researcher may not be that strong. So that researcher would think that it will be so nice if I have my paper with his name, it will give me additional value. And so whatever the strong researcher tells him to or her to do, they will listen to that more, even if they feel that it was not right. So you should not feel that, because your patients are your responsibility. And you should therefore see that they are not exploited, and the benefits and burdens go equally to them. And also one has to see the social and cultural, context in that, because suppose the proposal is from US, and then they ask you to do certain things which your people may not understand it that well, then you cannot actually execute that. You will have to ask them to change it, make changes. So when it comes to samples, etc., and all that, one thing, most important thing is you must have an appropriate MOU. And for the material transfer, you have MTA, material transfer agreement. So these are the two things which are taken into account when the Health Ministry Screening Committee actually looks into it, whether to approve that or not. And this committee's main idea is to actually protect the rights of the Indian scientists' intellectual property rights, and also see that sensitive information is not leaving the country. So then you have the section. This is actually very disturbing in between these things coming. I can't remove that also. Do you want to stop entering full screen mode when someone else, it's not moving also? What do I do if I put yes?
Shilpa, can you help madam in removing the unnecessary disturbance?
So this meeting is being live streamed. Okay, I do okay, but that again comes back.
We are able to see only your screen, nothing else, madam.
Okay.
You can continue.
Okay. Because one is telling me, what full screen mode when someone else shares their screen. So yes or no. If I do yes, maybe my screen will go. I don't know. I don't want to take that chance.
Please continue. We are going good.
Okay. So the ethical review procedure chapter is actually the biggest chapter in the ICMR guidelines. Always it had been the biggest one. So here you have all these points covered here, and most of them has been actually elaborated by Usha. So I'll just go through very fast about this. That is very important how you choose your members. The structure is very important, and they should be competent enough. And now 2017, before that, the guidelines said that the head of the chairperson can maybe preferably from outside. It was a flexible statement. But in 2017, to be in uniformity with the rules, it actually said that the person should be from outside the institution. The point is that the 2001 Good Clinical Practice Guidelines actually came after the 1 year after the ICMR first revision came out in 2000. And it actually was based on ICA GCP, WHO GCP, and ICMR guidelines of 2000. The point is that there were some ethical considerations which was lifted as such and placed in the Indian GCP. Because I was around during that time, so I know this historical development. So, but there they had specifically mentioned that the chairperson, that committee did not agree to this preferable thing. They said has to be from outside the institution. So the GCP guidelines, Indian GCP guidelines stated that the chairperson should be from outside the institution, but the ICMR guidelines said preferable in 2000 as well as 2006. But in 2017, it stated that should be from outside the institution because mainly to remove the bias. And they have to function, and they cannot function, by deciding things in the air. So a framework has to be created, and that's why you have the SOPs. And they should be independent in nature while making decisions. So the ethics committee not only looks at projects involving humans, but also their biological materials and data. A quorum is actually 5. It doesn't mean that 5 is the number, the last number. The point is, the ICMR guidelines say minimum 5. And the regulatory requirement is at least 5. So 5 is not the last word, because suppose you have, say, 15 members in the ethics committee, and then you say that 5 is the minimum, so 5 members only have come. That will not be accepted well by the quality review people, which Usha was mentioning. We have this quality review of ethics committee also, no? So when they come, they don't like that. If you had 15 people, then at least it should have been 50% plus 1. That's what they say. But this is not written in any guidelines, including WHO. So when next time the guidelines, our guidelines at least, when they change, maybe if the committee then constituted decides, they may talk about it, but I don't know at this point of time. But at least now we have that flexibility, but it should not go below 5. Now, when it comes to non-regulated clinical trials, they say any 5, but at least one of them should be non-affiliated, and preferably the lay person. So the lay person is a very important person, although in many ethics committees, they don't give any importance to lay person. And the regulatory requirement, you already heard about it, that there are specific requirements for these 5. You can have additional ones, additional medical science, additional clinician, you can have additional ones. But that day of the meeting, these 5 should have these specific members: clinician, legal expert, somebody from social science, and layperson. So risk category, actually Usha described about it. So in the 2017, we made 4 categories actually. Initially till 2006, it was only less than minimal, minimal, and more than minimal. Now, one more element got into this category to be at par with the international guidelines. So the main difference is that when you say less than minimal, you are actually talking about non-identifiable information. Remember this figure, and then you will not forget that. Non-identifiable information, because you are not actually dwelling into the privacy of the individual. Only when you actually get into the privacy of the individual, you are prone to actually cause harm to the patient and the participant in the form of stigmatization and things like that. So here there is no such element. So that's why it is less than minimum. Now, when we say minimal, it is actually based on daily routine life activities. Details you can see from the ICMR guidelines. So from here onwards, it's all identifiable information. So here it is daily routine life activities. And then it's a scale of lesser, the magnitude is lesser when there's invasion of the body, either physically or mentally. When I say physically, that means you are drawing blood, you're taking biological materials, CSF, all these things, you are invading the body. So that is physical. But if there is a the social science research, you will also be invading the mental setup of the individual. So depending on the magnitude of the harm, you have this minor increase and more than increase. So here, highly invasive, you can very easily make out which is highly invasive. So here, of course, a lot of more work is required for that. So why do we actually classify all these things?
Dear madam, time is running. Last 5 minutes will be okay for you?
Yeah, I will actually, I will not describe much.
Yes, yes.
So the thing is, you have exemption expedited full committee based on this risk element. So you have, you should take exemption certificate. Otherwise, sometimes, journals will refuse that. In expedited, you have a small committee, and in full committee, of course, the full number. Decision making, approval, minor revision, major revision, and not approved. Broad consensus of 50% plus one voting. Then you also have continuing review. It's not enough if you actually give approval initially. So you need to have progress report, protocol deviation, protocol violation, non-compliance, AE, SCE report, new information, or any changes have to be reported, and EC has to take a view on that, and then final report. And then you manage the injury, medical management first, and then over and above that financial, which is clearly described in the NDCT rules. But in the academic trials, it's still a gray zone. And ethics committee is wholly responsible for deciding that. Site monitoring is, of course, important. The routine for higher risk proposals and vulnerable participants, and then for cause, reasons for concern. And you can look at these reasons in the ICMR guidelines. If that is the case, it will be on-site. And if this is the case, it can be off-site. Or routinely also you can go. So record keeping, I will not go into details about this. You can also have electronic storage. Accreditation, you already heard about that. There are 3 bodies in India doing this quality review. One is the American one, and then this is the WHO initiated one, and this is our own country's NABH. Coming to the 5th, informed consent, there are essential elements there. There are electronic consent ways of waiver of consent, re-consent. And in some communities, when you enter, you have to take gatekeepers' permission. In school, you go, you take the headmistress or headmasters or the principal's permission. Without that, you can't go. So you should remember that in certain areas, you cannot enter without permissions from the responsible people. You can also have deception. And where does this come? We'll talk about it later. Then the key elements are how you communicate, how the person understands, the ability to understand, documentation. And one should not actually use therapeutic misconception. Voluntary participation should be there. A copy should be given to the participant if it is a written consent. Then you, of course, the document has 2 parts, mainly patient information sheet and then endorsement of that by the participant called the informed consent form. If they cannot actually give, for some reason they cannot consent, then of course the role of LAR comes in, who assures the voluntariness of the participant. It can be written, oral, audio, visual. So in ICMR guidelines, you can see informed consent document, the page 50. These are the essential elements which should be part and parcel of any informed consent document, and these are the additional elements. written when they are literate. When they are illiterate, can be thumb impression oral. And in both cases, you can have audio or audio visual. There are instances of waiver of consent on page 54 of ICMR guidelines. Assent when it comes to children, 0 to 7, no assent, 7 to 11, oral assent, 12 to 18, written assent. In all cases, parental LAR consent is required. But if the child refuses to participate, you can't enroll the child. So audiovisual recording, you all know that in the regulated clinical trials, it's made mandatory that if you're using vulnerable population, then you have to do audiovisual recording. It is relaxed only in the case of HIV and leprosy. Coming to vulnerability, there's always actually likelihood of people being wronged. Because they're incapable of protecting their own interests. So there can be many, like age or medical condition related, situational, like economically and socially disadvantaged individuals, or communities, etc., having hierarchical relationships, institutionalized persons, or humanitarian emergencies, language barrier, because most of the states have these migrant population doing the menial work. So cultural differences, etc. And they should be included only if it directly answers their health needs. And they have an equal right to be included in any research for the benefit that they can get out of that research. Ethics committees should employ the safeguards for that. Clinical trials is again a big chapter. You have regulatory clinical trials, non-regulatory clinical trials. There are many things actually described under that, cannot actually explain that. Only difference is when you talk about regulatory clinical trials, they have a commercial nature and sponsor is responsible. We have some formula at least to calculate, to come to a decision. But when it comes to academic or investigator initiated, it should be purely academic. But when there's some overlap, the ethics committee can inform the CDSCO and wait for NOC for 30 days. And this has been actually incorporated into the NDCT rules also. But here the institution is actually responsible for the quality of data generated, safety of intervention, and compensation. I already told you about the compensation that the institution should have. Public health, of course, is a very thin line between service and research. So there are various things described in this chapter. Only thing one has to be very, very clear about the informed consent process, whether it should be verbal, oral, etc., or whether the ethics committee can. Always the ethics committee takes a decision on that, whether it can use, that project can use waiver of consent, reconsent, etc. So, and you must remember, when we talk about public health, it is not for one individual, but for a whole community. And the same thing goes for social and behavioral sciences, which overlaps a lot with the public health. And one important thing is about deception studies. The topics are so sensitive sometimes that if you go to these participants or in that community, you will be thrown out because it will not be acceptable by that community. So sometimes you may have to use, there are 3 ways in which you can use deception, which is described in the ICMR guidelines. Qualitative research is very much a part of that. And then sharing data, how do you do that? Now, when we always talk about safety of participants, we must also remember the research teams also require safety measures in such type of projects, because the topics are so sensitive. They are always a danger most of the time. Some research teams have even asked for insurance. Section 10 is on human genetics, which again is a very thin line between service and research. And here, mostly you have to be careful about stigmatization and discrimination. So you need to have genetic counseling prior and post enrollment. And then also, you have family secondary participants, because genetics, like public health, we said it not only involves the individual, but the community. Genetics also does not involve the individual alone, but also the family. So one has to be very careful about that. Biological samples, if you take, this is a very important issue. We'll talk about that later. Biological material. So here the ownership business, I will tell you about that. The point is that when you store these, there's always an element of making money by, making kits, which are commercially viable. So what comes back to the participant? Nothing. So there have been issues and case laws, etc., based on that. Not go into detail about that. One is obliged to return the results. And biological material and data and forensic departments is specially described in this chapter. And when you talk about data sets, anti-hacking measures, etc., should be taken care of. Then we actually codify the material into anonymized samples. So if you go back to the link, then it is called reversibly anonymized. If you cannot, then it becomes irreversibly anonymous. And irreversibly anonymized is equal to anonymous. And that has the highest safety, because confidentiality is not a question here, because nothing is available to identify the person. So here it is partially covered, but here it is obvious that you can identify. Now, this is where I want to make it very clear that ICMR guidelines is very clear. The one who actually donates the biological material is the owner. And the one who does research on that and the institution are only custodians. So if you keep that principle in mind, lots of problems will be solved. Two options you have to give to the patient, the participant, when you use biological material. Can the person allow use of the sample or not allow use of the sample? Because secondary use is what you use the same sample for another project. Now, that will be possible only if the person has allowed the use. If they haven't, either you take a fresh consent or the person point blank refuses to give consent. The second option is whether to inform the result or not. The option should be given to the participant. I'm not going into detail about that for want of time. And this is the last chapter on humanitarian emergencies and disasters, where, if you know the cyclic nature of natural disasters, you can prepare a proposal, get the approval of the ethics committee, keep it ready. And when the disaster happens, you just go ahead, but inform the ethics committee that you have started the study. So lots of things are actually problematic here, informed consent and all those things. And another thing is international participation. You saw in COVID times, there was between countries, there was cooperation between the same country, between different institutions and within the institution departments. So this is called principle of solidarity. So that was very much evident at that time. One important point that I would like to highlight here is that ethics review procedures actually allowed virtual meeting. Otherwise, it was always a meeting to be held in person. So this is the only condition where this was allowed. And this was the reason, actually, this is a chapter based on which the COVID guidelines were made. And in the COVID guidelines, you have virtual meetings. And you know very well, even now we are doing a virtual meeting. So nobody has said now that you can't hold virtual meetings. So if you look at the other guidelines that have come by, these are for children and the stem cell in 2017. The 3 guidelines were released together in 2017, including the ICMR ethical guidelines.
Madam, time is running.
This is last. This is last.
Yes.
And 2019, you have the gene therapy and the publication ethics, the research integrity and publication ethics guidelines for ICMR, but others can follow that. Then we had the COVID guidelines, and then 3 in running on AI, multicentric research, and the CHIS, that is the controlled human infection studies. were released, and 2024 early enough we have the multicentric systematic review process, what should be done. Those guidelines are given here, and this is on the laboratory scenario. With that, I end my talk. Ethics is knowing the difference between what you have a right to do and what is right to do. Thank you for your patience.
Beg, sir, you can have one or two questions.
Thank you so much, madam, for the wonderful session. I hope every one of us, all the delegates, are privileged to listen to your insightful sessions. And I hope your immense experiences and those important aspects which you have defined is more significant for us. You have tried to cover almost every aspect of 2017. Happy to listen to you about your old experience also, madam. Ganesh sir, I feel let the audience have the chance to interact with our esteemed speaker. Please go ahead, sir.
Madam, there is one question. Are there any tools for ethics committee to do the benefit risk assessment?
Yeah, actually, I didn't dwell much about it, but it's the tool is up to the ethics committee to use. They have been actually, people have tried many ways. They have had this low risk and high risk. They weight against like odds ratio and all those things. Those are there, but there's no time for, having any mathematical calculation there. You have to just compare the risk against the benefits and see which weighs more. If risk is more, you have to see whether it is justified. That is the basic principle.
Okay. How can ethics committee take care of principle of distributive justice? What is the responsibility of ethics committee in this situation?
Yeah, so the ethics committee would see who are you enrolling. The criteria is that. Now, it can find that there's no non-compliance only in monitoring. Then only they will know that these people are only including the BPL card holders and not the others, depending on the disease that is affecting them.
Last question is, can you throw light on example of studies using deception?
For example, you see, you want to study the behavior of a particular tribe. You just cannot barge in and, say, we have come here to study your behavior. Most of the time, what happens is the researchers stay with them, observe them, and study their habits and behavior without disturbing them. Okay. So at that time, how they have to take from the ethics committee, they will say that they will not inform the tribals or the participants about it. So that means they are not telling the participants, what their purpose is. So that is a deception.
Yes, yes. Last question, can postgraduate act as a principal investigator or PG guide will act as a principal investigator?
This is what I was explaining.
Yes,
the
yes.
PG guide will be the investigator, and the student will be student researcher. But when it comes to publishing the paper, then of course the student should be the first author, but we very often see it's not the case.
Yes, yes. Thank you so much, madam, for your kind lecture. Now I request Dr. Kamal sir to speak few words on this occasion. Over to Kamal sir. Are you there, sir?
Am I audible, sir?
Yes, sir. Yes, sir. Go ahead.
Can you hear me, sir?
Yes, sir.
We just want to communicate to our participants that thank you very much for your support, and this is overwhelming response to this GCP workshop. I just wanted to share information that 75% attendance are mandatory to complete this course of GCP that our accreditation or academic board have decided. And we have already started working on the certificates, and just wanted to communicate from this test that it will require certain period of time to send all these certificate, because there are exuberant numbers of the participants, 1500. So it will take time. So there need to be some patience, but we will remain in touch. And for any kind of the query, they can contact us on email. Thank you all.
So lastly, I am very thankful to both the speakers, Dr. Usharani Pingle Madam as well as Dr. Nandini Kumar Madam, for their excellent, concise and conceptual presentation, as well as moderators, Dr. Lalit Kumar Gupta sir and my friend Dr. Beg sir for this nice moderation. Lastly, my sincere thanks to all participants for their active participation and patience hearing. So with this, now I declare that today's session is over and we will again meet on our last session on 28th of March at 3 p.m. Thank you all.
So before parting, I would like to apologize for, not being able to contain the whole talk within 20 minutes.
Okay, madam, no issue.
Drop so many things for that.
Yes, it's no issue, madam, no issue at all.
Thank you.
Very,
very
very, very
much.
interesting. And we are benefited the in-depth knowledge, and we are really impressed by the way of the presentation that you have made. So really, really very nice. And the entire recording of the presentation shall remain on YouTube forever. And those who can listen it again, I think it will be very beneficial. Those who are unable to find time this time, they can log on YouTube channel also. Thank you very much. Thank you, madam.
Thank you, sir. Thank you.
Thank you.
Thank you, madam.
Thank you.
Thank you, Ganesh sir.